Harry, how's it going? Nice to meet you. Come on in.
Thank you, mate.
Put yourself there, everyone. So, shoulder.
Yes, left shoulder.
Left shoulder.
Yes.
Great, okay. You've had a few different people look at it, by the sounds of it. 5 years.
5 years.
Yeah.
5 or 6 injections.
Right.
So let me start at the beginning.
Yeah.
About 5 years ago, I started getting pain when lifting or when even just moving my arm around.
Okay. Lifting weights?
Lifting weights.
Yeah.
And then it became an everyday occurrence where it was just moving my arm generally.
Right.
They did multiple scans, number of injections, etc.
Yeah.
Frozen shoulder, then it was impingement as well.
Okay. Did they say what it was impinging? Was it rotator cuff supraspinatus?
Supraspinatus.
Yeah. Okay.
But yeah, I still have pain on the extended ranges of motion, be it out to the side or up.
Okay.
So I'm just trying to relieve that, really.
Yeah. Yeah. And does that physio help? The exercises that you've been doing working on the left scap?
The physio does a number of things. They do acupuncture and they sort of work out different knots to try and open myself up a little bit.
Yeah.
And then they give me exercises to do in the gym, etc.
Okay.
It's helped with my posture and pulling my shoulders back and opening my chest. But I'm still getting the impingement pain when doing the range of motion.
Okay.
So it runs down here.
Okay. Is it tended to touch anywhere around there at all? Not tended, just when you move it?
It's just when I move it.
Okay, and you're getting it down to there?
Yeah, and it sort of goes around this area.
That's a common referral point of supraspinatus tear.
Yeah.
So
it's getting very tedious now. Over 5 years not being able to, or just having constant pain when I do certain things, it just gets very tedious.
Okay. There's a muscle called serratus anterior, which is the easiest way to explain it. Anyone in the bodybuilding world, you see them do this pose, which is a lat spread kind of thing, and it's serratus anterior that's working. And the reason that I mentioned that, I think that's one of the first things that I'll take a look at, because has that muscle even been mentioned to you at this point?
No.
Okay. That's good for me, because it means that there's probably something that we can do. Yeah. There probably is anyway, but if that's not been mentioned, that's massive low-hanging fruit, I think, for me that we can look at. And what it does, scapula. So you've got scapula on the rib cage, and you've got, it seems like a lot of attention's been put, as it usually is, on the muscles that connect the scapula to the humerus, which is the rotator cuff group primarily, which are the ones, supraspinatus is the one that's probably got a tearing for you. But then you've got to look at how the scapula connects onto the rib cage, and there's serratus anterior in there that connects that to that. And quite often what it is, there's any lack of movement in the scapula or it's weak in some plane, it's usually that muscle. I don't want to make assumptions, but that's one that we'll have a good look into to start with. I think we'll jump straight into it with the test that I'm going to show you, which is wall press, basically. So this is it's not quite a push-up, I'll demonstrate for you. You're going to be in a push-up position, so arms against the wall, shoulder height, shoulder width apart, like that. And then all you're going to do is retract, which I know you said you're a bit weak with, but we'll see how that goes.
Yeah, I can't do this.
And then do the opposite, which is protract. And the only thing that I want you to think about, just work through with a few reps and just wait for things to loosen up, because they can take a little while. The only cue I want you to remember is to keep your shoulders low. Because usually when people do that, the first thing that happens is they shrug.
So that's what.
It's not bad range of movement, to be fair. So squeeze and then push. Good. I would say, because the scapula, they're not properly winging, but they're kind of sitting off the rib cage a little bit at the inferior angle below, which shows you that serratus anterior in there probably isn't doing what it should. But just go again with the push. That's the one that we're trying to be. Can you feel that difference right to left? Have a feel of the muscle mass just in there. That's serratus anterior, the bit that you can palpate, and then have a little feel on the left side.
Yeah, there's nothing.
Yeah. Okay. So that is, straight away, that's something this left side needs to be improved. The difficulty there is I can give you exercises that will help with serratus anterior, but when you've got something going on in this shoulder mechanically that we know is happening, then that can inhibit the whole area and the muscle just doesn't want to work. So what we've got to do is find a way to get that switched on for you. That's the challenge. Just try and think about tucking those shoulder blades into the back pockets. And if you get any pain at any point, let me know. Any difference there that you're feeling?
No.
No. It's, oh, keep going. I mean, sometimes just with someone touching in that area, you get that sensory feedback and the muscle starts to switch on a bit. But where I'm pressing there with the left is really where you want to feel working. Go one more time. Any pain during that at all?
On the decline, yeah.
Okay.
Going down here.
Right, okay. A bit of a unilateral thing now. So you're looking at the right side first, just so you know what's the normal sort of, how that should feel. What you're looking at here is purely scapular rotation. So what I mean by that is, don't think about shoulder pressing it or Arnold press, because that's not what we're looking for. What we're looking for, and you're going to have a feel, and I'm going to have my fingers in there too, is literally palm facing you, arm straight, and then push up until you can't push up anymore.
Okay. And
that's quite a kind of abbreviated range of motion. It's just that.
Okay.
So any more than that and you'll have to find yourself turning out. So keep that facing you. Okay. Go to the right side first. You weren't expecting a gym session today. Have a sit down as well, because then I can have a feel.
So like this.
That's it, yeah. And then bring the elbow down first. Good. And then push up. Good. And then don't come quite so high, probably just about there. Good. Very restricted range that we're looking at, which is all we need. Excellent. And now I can feel serratus anterior working fantastically. So that's how it should feel. We'll swap to the left side, and you get any pain, don't push through it because I don't want to irritate it. Fingers in here and go for it. I can feel that. How's that? Is it painful or is it just difficult?
It's just difficult, it's just weak.
Yeah.
Until I get to beyond that point, it's all right.
Right. I can feel that working now, where it wasn't working before. This is definitely an exercise that I want you to put in.
Okay.
Yeah. Bring the arms in. Anything?
It gets to sort of there.
You feel it?
Slightly.
Okay. I'm going to give it a light push. I want you to resist my push. A little bit of weakness there in the left side. That's fine. Can you show me rotation? So you're going to get elbows tucked into the side and then rotate the arms out. What's stopping you there?
I don't know. It just...
Oh, it doesn't want to go?
Yeah.
Right, okay.
But if you pushed it, it would.
Okay.
It's just I can't make it do it myself.
Interesting. Yeah. Okay. That's helpful, actually. That is actually pretty restricted passively. Yeah. So it wasn't just a lack of strength in the external rotators, but actually there's a bit of tightness in the internal rotators as well. Have you ever had any work done into there?
There's quite a few, well, there usually is quite a few knots in there.
Okay. Because what we want to do is get you a bit more external rotation. Yeah. How much of that is restricted by the capsule, we'll find out.
Yeah.
It'll either get to a point where we physically can't make any improvement, or you'll get pain, or ideally neither, and you'll have the same as you got on the right side.
Perfect.
Okay, nice and relaxed. Anything causes pain, you let me know. Retraction, protraction. Could do with a little bit more protraction. Any pain there when I'm doing that?
No.
Okay. Elevation, depression, downward, upward rotation. Yeah, the only thing you're lacking there's a bit of protraction, which completely lines up with what we saw with the wall press, that you're lacking it. So it's not just a case of you're lacking it actively from serratus anterior not doing its job, but also there's some restriction here that's stopping it. So what we'll aim to do now is get that moving into protraction a bit more and get some more rotation through this arm, both internally and externally.
Yeah, perfect.
So that's where we'll start. And that is indeed where we began. So the main aim of the treatment side of this session is to get that scapula moving into protraction and also upward rotation. So we're going to begin with some work just inside the medial border of the scapula, onto the rhomboids, mid-traps. All the soft tissue work that we do is there to complement what Harry needs to do with his rehab stuff, which really is where the majority of the good work is going to be done, because we know that serratus anterior is underactive. We've got the cups on there as well, which very, very quickly just light the area up with erythema, get those soft tissues moving. And all of this is just designed to help me get the scapula moving when I need to, which we'll see a little bit later on with some mobilizations and METs. Propping the arm up so that we can shorten that infraspinatus a little bit, and we can start to get in there and find some trigger points as well, which on the time lapse you won't see, but you can see there I'm just keeping that ischemic pressure on certain areas, and that's to treat those trigger points, indicated by a couple of twitches, and also Harry just saying that they were particularly tender points. So we'll move on to mobilizations and METs, but before we do that, we're just going to try and get the scapula moving. Now the soft tissue work's done, trying to get that scapula into protraction passively, and then finishing off there with some traction to get the glenohumeral joint moving as best we can. So we want to get a bit more external. As I push you into the end of range, you got any pain there?
If I relaxed it, probably you went a little bit further than probably, but
okay.
Not at this moment in time.
Right, and then we'll go the other way. Just want to make sure before I go sort of pushing it into further range, I'm not just going to cause you pain.
Going that way is easy.
Yeah, there's more range there now as well. Right, get a bit of work done first on subscapularis. Now moving on to some subscapularis work, some STRs, taking the arm into external rotation to stretch the muscle. Alright, we'll try a couple of METs as well. With this, I am going to try and push you into a further range, but the number one important thing is that you don't get a twinge.
Yeah, no,
even if it's the slightest twinge in that usual area, you say.
Yeah, that's all good.
Okay, light push into my hand here with your wrist. Hold that. I'm going to go for about 8 seconds. I'll let you know when to relax. Okay, relax. Now the soft tissue work is done on the infraspinatus, we can use some METs. If you're unfamiliar with METs, look them up, learn them. They're very, very useful and effective. You contract the muscle for 8 to 10 seconds before we take it into a stretch. When I move it back to neutral, so start position, I want you to kind of push into my hand. I'm going to give you some resistance, and I'm going to let you win, okay? So slow push. Good. Any pain there?
No, normally I do though.
Yeah.
So having, I think pressing against you, does that relieve it?
What it does, so the difference, that's the reason I get you to do that, let's just move this into the arm, is because the difference between passive movement and active movement, if I was just to keep you relaxed and move your arm, the muscles, the rotator cuff around the head of the humerus aren't supporting that joint. So what's in there is just subject to the movement of the bone. But by getting you to push into me, I'm including the rotator cuff muscles in the movement, and they're supporting the head of the humerus. So again, that tells us that it's probably a bit more required in terms of stability from the rotator cuff. So when we get you back up, we'll have a look at a couple of banded exercises. Nothing new, but I just want to see what you're doing. And the interesting thing is that you weren't doing any internal rotation, and I think that's probably going to be quite important. Even though technically you don't need more internal rotation, you need balance between the external and internal rotators. Temperature okay?
Yeah, all good, man.
Okay, lie down onto your back. So that will start to sink down. So arms down by your side, just let him relax, that's good. You will have seen me place the bolster underneath the spine. That opens up the pecs, and we're just doing some soft tissue work there to get those shoulders out of the protraction that we know that they're in. And after that, we move into the sideline position. With the arm supported, this is a very effective mobilization. It allows the scapula into retraction, and that then lets you get your fingers underneath the medial border, and you can use that arm to kind of traction the arm, but also to mobilize the scapula, lifting it up and getting it moving. And it's that soft tissue work that we did earlier on that makes this technique now so effective. So similarly to the uppercut press, all we're thinking about here is working infraspinatus teres minor around the back. So they're the muscles we should feel work.
It's just so weak.
Does that feel quite weak, that side?
Yeah.
Struggling to do it?
Yeah.
Okay.
I guess if I'd stayed there, it would start shaking. Sort of.
Yeah. That's fine though. I wouldn't want you to go any further than that. I think neutral is where I stop that movement. Let's have a look at internal rotation as well then. So if you just literally switch places with me, same rules apply. You're going to go from neutral to there. So I never really want to see arm that way.
I find that so much easier.
Try and think about keeping that elbow completely squeezed into your side. So, because at the moment the elbow is coming out just a bit, so really keep it squeezed in and then go. It's a tricky one, this, because there's a lot of other muscles that can take over the movement. To get subscap to do it all by itself is really difficult.
Yeah, I'm trying to keep my shoulder down as well.
Yeah. So there's a little bit more like mental effort, I think, going into holding that shoulder position still while you do it. Because what's probably happened, and not just you, but everyone who does any exercise without thinking about everything involved, is you'll learn to do it, you'll get really efficient, but in the wrong areas.
Other things to take over.
Yeah, and then they get really good at taking over as well, because that's been reinforced.
So I can feel my trap activate when I do that.
Right. So there's probably another emphasis on keeping that down. And if you need to find a way to keep the shoulders depressed, is always just start with elevation and then go in the opposite direction. Just sort of tuck it in using serratus anterior. Cool. So plan going away then, I mean, obviously it's supraspinatus impingement, there's a tear in there, but the lack of serratus anterior involvement on that left side is not giving you the foundation that you need to keep a solid base with the scapula and then with the humerus going into that. Also, the wall press that you're doing, you can do a few of them as well as an activation before you do the dumbbell press. So if you're on your warm-up weights, so you got like a 10 kg, 14 or something in your hand, then what you can do is with the arm out, you can just keep the arm straight, come back, and then push up to the ceiling.
Okay, yeah, that makes sense.
Yeah, exactly the same as the wall press, but with that. And then that engages serratus anterior in a functional way, because then when you're lying there doing the bench press or dumbbell press, you're ready to go. Keep these locked in, keep the lats tight while you go.
No, that makes sense,
That's why.
All right, so that was a 1 hour session with Harry, first time that I've met him. So in summary, I'm just about to write my notes. And this is the kind of thing that I'll write. It will be something like confirmed supraspinatus tear, some scar tissue and things like that from the surgery, from the removal of the spur on the head of the humerus. But ultimately, the objective findings were that serratus anterior on the left-hand side really wasn't working very well at all. I wish you could feel what I could feel, which was not much. So you can kind of imagine. Harry could feel that as well, so which is really helpful. The hard part will be for him to get that muscle working, because that's just repetition and consistency. What else? He had restriction and a lot of weaknesses you would have seen in banded external rotation or resisted external rotation. So those external rotators, infraspinatus, teres minor, really need to start working properly. The fact he wasn't doing any banded internal rotation or any internal rotation loading at all, even though he was quite strong with it, there were still some corrections to his position that we needed to make. So he's going to be responsible for making those. So we'll see how he gets on next appointment. He's also going to do an uppercut press, this one, to get serratus anterior working on the left side. And again, palpate just to make sure he's completing that feedback loop. He can feel it, the sensory feedback is working. That reinforces that muscular recruitment. He needs to do banded rotation both ways as well. With something in between his elbow, you can see, quite a big guy, big lats, so the elbows come out to the sides. See, elbows come out to the sides. So he really needs to be thinking about keeping that tucked in. He needs to retain that good scapular set position, which is ultimately protraction combined with depression. That's the theme. That's what we're going for with serratus press. Why is he doing all of these things? Well, he needs that to translate eventually to what he wants to do, which is lift without pain. He can build strength in the right way, in the right muscles, and not exacerbate the injury. So I've encouraged him to begin loading, so start a dumbbell press, which actually said to me towards the end he did, but to try and carry over the positional things that he learns from the uppercut press and the wall press into that. So that scapular position that he begins with, just imagine I'm lying on my back, will be, he's there with the dumbbells ready to go, but before he does so, it's going to be scapulars depressed and protracted. So now he's got the foundation in the scapula to allow him to move like he should be moving. It's taking some of the stress and strain off the ball and socket joint, the rotator cuff where that impingement is. Will he need surgery? Will he need another cortisone injection? At this stage, who knows? We'll have a clearer and clearer picture every time I see him now. So he's coming back in 3 weeks. I've asked him to be very consistent with the exercises during that time. When he comes back, the two most important things are going to be subjective assessment and objective assessment, and we're trying to see if there are correlations between the two. Subjectively, he needs to tell me, ideally, yep, things have improved, they're feeling great. I can then assess him and confirm, have the objective assessments improved? Has he got more range of motion? Can he get serratus anterior to contract a bit more? Are his external rotators of the left shoulder stronger than they were? If not, then we need to possibly take another look at the exercises, reassess. Hopefully that matches. If he comes in and he says subjectively, no, it's not any better, then I take a look at the movement, same process. But we're trying to figure out, has he been doing the exercises correctly? Is there anything else that we're missing? Am I just completely barking up the wrong tree? We'll only know session on session. You will have noticed as well, nobody has mentioned serratus anterior to him. And I know I seem like I've got a fixation with that at times, but this is probably why, because nobody's mentioned serratus anterior to him before, and it was the first thing that we saw as the underactive. So I hope that's been helpful. I would love to hear your comments or any questions down in the comments section. And thank you so much for watching. I enjoy this stuff. I love it. This is me, as you will see me in clinic. The camera's presence really makes no difference other than the fact I'll probably talk a bit too much. So catch you later. Thanks for watching. Bye.